Welcome back to the deep dive. Today, we're completely shifting the atmosphere. I want you to forget about a casual commute or a relaxing jog.
Okay.
I want you to mentally transport yourself to a very specific high-stress environment. Picture the hallway outside the examination room at Gujarat University. You are wearing your white coat, your roll number is pinned to your chest, and you are about to walk in for the MD anesthesiology Viva Voce.
Oh, that is a feeling every anesthetist remembers. The dry mouth, the racing heart, which is, kind of ironic considering the topic we are discussing today.
Exactly. So you walk in, you sit down across from the senior faculty, and they don't ask you about some obscure genetic syndrome.
No, never.
They look at you and ask about the absolute bread and butter of our trade. They ask you to compare and contrast atropine and glycopyrrolate.
It sounds deceptively simple.
Oh.
And that is exactly why it is a minefield.
Yeah.
The examiners know you use these drugs every single day. Because of that familiarity, they expect your knowledge to be absolute. They expect granular detail in the pharmacology, the chemistry, and crucially, the clinical decision-making.
Mm-hmm.
If you stumble here, you don't just lose marks.
You lose credibility.
You lose credibility, absolutely.
So our mission today is to function as that high-stakes exam prep session. We are going to deconstruct these two drugs using the gold standards, Morgan and Mikhail, Miller's anesthesia, Stolting, and of course the Bible of pharmacology, K.D. Tripathi.
Good.
We are strictly following the Gujarat University exam pattern. We've got the outline, and we are going to drill down into every single section.
Okay, let's treat this as a mock Viva then. I'll play the role of the senior examiner, and we will work through the logic together. The goal is to move beyond just memorizing a table.
Right.
It's about understanding the physiological first principles behind your choices.
Perfect. Let's start with Part A, Introduction and Exam Framing. Before we get into the molecules themselves, let's set the clinical stage. Why are these drugs so fundamental to what we do in anesthesia?
To understand that, you have to understand the autonomic nervous system. Anesthesia, our entire job is to act as a disruptor of autonomic balance.
That's a good way to put it.
We give drugs that depress the sympathetic system. We perform maneuvers like laryngoscopy that can massively stimulate the vagus nerve. We deal with reflexes constantly. The anti-muscarinic drugs atropine and glycopyrrolate are our primary tools for modulating the parasympathetic side of that equation.
You just used the word anti-muscarinic. Let's pause right there, because that's important. In the OT, we often just hear the term anticholinergic. Pass me the anticholinergic. But in an exam setting, is that terminology acceptable?
It's acceptable, but it is imprecise. And in a master's level exam, precision is what earns you distinction.
Okay.
Anticholinergic is a really broad umbrella term. It implies blocking the actions of acetylcholine everywhere. But you have to remember, acetylcholine acts on two very distinct receptor families.
Muscarinic and nicotinic.
Muscarinic and nicotinic. And the nicotinic receptors are at the neuromuscular junction and the autonomic ganglia.
So if these drugs were true anticholinergic.
Exactly. If atropine and glycopyrrolate were truly broad-spectrum anticholinergics, they would block the neuromuscular junction and cause paralysis.
Which they obviously don't.
Obviously not. They are specific competitive antagonists at the muscarinic receptors M1 through M5. So the most accurate term, the one that tells the examiner you know your receptor physiology, is antimuscarinic.
That's a great opening point for a Viva answer right there. Now, the role of these drugs has shifted over time, hasn't it? Historically, they were used for a very different primary reason.
Drastically. Yes. If you go back to the classic texts, and Morgan and Mikhail discusses this really well, during the era of diethyl ether, the primary goal was to be an anti-salagogue.
A what?
An anti-salagogue, a drug that dries secretions.
Oh, okay.
Ether was incredibly irritating to the respiratory tract. It caused patients to produce just copious secretions, foaming at the mouth, risking laryngospasm, so you had to dry them out before you even started.
But today, with sevoflurane, desflurane, and propofol, we just don't see that kind of irritation.
Correct. So the drying effect, while it's still useful in certain situations, has become secondary.
So what's the primary role now?
The primary modern role is hemodynamic stability, preventing or treating vagal bradycardia, caused by surgical stimuli or other drugs like sexmethonium and fentanyl, and, I would say most importantly, managing the side effects of neuromuscular reversal agents like neostigmine.
And that shift in clinical use is what dictates the exam questions. I've looked at the patterns. You see short notes on, say, pharmacology of glycopyrrolate or the dreaded central anticholinergic syndrome.
Yes.
But the Viva, the oral exam, is almost always a comparison. Why did you choose glycopyrrolate over atropine for this specific patient, or the classic tabulate the differences?
And that tabulation is the ultimate test. It's not just memory. It tests your understanding of chemistry, physiology, and clinical judgment, all at the same time.
Okay, let's get into the engine room then. Part B, Basic Pharmacology. The outline labels this section absolutely essential and exam core. So we need to talk about chemistry.
Chemistry is destiny. I cannot stress this enough. If you can understand the chemical structure of these two molecules, you can derive, I'd say, 90% of their clinical differences without having to memorize a single thing.
That's a bold claim. Let's start with the prototype then, atropine.
Atropine, it's a natural alkaloid. KDT, KD-tropathy, reminds us it's derived from plants like Atropa belladonna, the deadly nightshade, and also Deuterostramonium.
So it's been around for centuries.
Oh, yes. But chemically, the defining feature, the fact that you must write in bold letters on your exam paper, is that atropine is a tertiary amine.
Okay, let's unpack that. Tertiary amine. What does that actually mean for its behavior in the body? I mean, for us as clinicians.
It refers to the nitrogen atom in its core structure, in the tropine base. In a tertiary amine, that nitrogen atom is bonded to 3 other organic groups. And crucially, in this specific configuration, the molecule can exist in an uncharged, non-ionized state at physiological pH.
And uncharged means lipid-soluble.
Precisely. It is lipophilic, it loves fat. And because our biological membranes, like the blood-brain barrier, the BBB, and the placental barrier, are essentially lipid bilayers.
They're not really barriers to atropine.
Not at all. Atropine sees them not as walls, but as open doors. It crosses the blood-brain barrier freely. It crosses the placenta freely. It distributes into every single compartment of the body.
So you could almost think of atropine as a stealth agent. It infiltrates everywhere. The brain, the fetus, the eye, the heart.
That is the perfect analogy and a great way to remember it. Now contrast that with glycopyrrolate.
Glycopyrrolate is synthetic, right? It's not from a plant.
Correct. It's a man-made synthetic quaternary ammonium compound.
Quaternary. Okay, so the nitrogen atom has 4 bonds instead of 3.
Yes. It has a quaternary nitrogen atom, and that 4th bond is a complete game changer. It forces the nitrogen to carry a permanent positive charge. It is fully ionized all the time.
A charged molecule.
A charged molecule.
The charged molecules hate fat. They're repelled by it.
They are lipophobic, they are hydrophilic, they love water. So when glycopyrrolate is traveling through the bloodstream and it hits the blood-brain barrier,
It hits a wall of fat.
it bounces off. It cannot cross. It hits placenta, bounces off. It stays in the systemic circulation.
So if atropine is the stealth agent, glycopyrrolate is more like a heavily armored tank. It stays in the streets, the blood vessels and tissues. It does its job there, but it never enters the headquarters, the brain.
Exactly. I love that. This tertiary versus quaternary distinction is the single most important concept in this entire deep dive. It explains why atropine can cause confusion in the elderly and glycopyrrolate doesn't.
And why atropine can treat fetal bradycardia and glycopyrrolate can't.
It explains everything.
So just to be clear, the mechanism of action for both is the same at the receptor level, correct? It's competitive antagonism.
Yes, exactly. They both physically compete with acetylcholine for the binding sites on the muscarinic receptors. They don't activate the receptor. They just sit there and block the key from entering the lock. It's just that their distribution, where they can go to do that blocking, is completely different.
Okay, we have the chemistry anchored, tertiary versus quaternary, lipophilic versus hydrophilic. Now let's see how that chemistry translates to the different organ systems. Part C, pharmacodynamics and pharmacokinetics. The outline calls this exam gold. So let's start with the heart.
The cardiovascular system. We all know that both drugs cause tachycardia. We see it every day. They work by blocking the M2 receptors on the sinoatrial, or SA, node.
Normally, the vagus nerve releases acetylcholine onto those M2 receptors to slow the heart down, so these drugs are essentially taking the foot off the brake.
Correct. But there is a massive nuance with atropine that examiners absolutely love to ask about. It's the paradoxical effect.
Paradoxical bradycardia. This is the classic Viva trap question, isn't it? Does atropine always speed up the heart?
And the correct answer is a confident no. If you give a low dose of atropine, and that's typically less than 0.4 milligrams IV in an adult, or if you inject it very, very slowly, you can actually see an initial transient slowing of the heart rate.
So why does that happen? I mean, it seems completely counterintuitive for an anti-muscarinic drug.
It's a very specific mechanism that involves presynaptic receptors. As it's detailed in KDT and Stolting, There are M1 muscarinic receptors located on the presynaptic nerve endings of the vagus nerve itself.
So these receptors are on the nerve, not on the heart muscle.
Right. And these presynaptic M1 receptors act as kind of negative feedback loop. When they sense acetylcholine in the synapse, they tell the nerve, okay, that's enough. Stop releasing acetylcholine. They inhibit further release.
So they are the brakes on the vagal nerve's output.
Exactly. Now, atropine, especially at low doses, seems to have a higher affinity for these presynaptic M1 receptors. It blocks them before it gets around to blocking the postsynaptic M2 receptors on the heart.
So if you block the feedback brake on the nerve,
The nerve thinks there isn't enough acetylcholine being released, so it panics and dumps more acetylcholine into the synapse. You get this sudden surge of vagal output, which temporarily overwhelms the heart's SA node and causes that transient bradycardia.
that is fascinating. So a low dose leads to presynaptic M1 blockade, which leads to increased acetylcholine release, which causes bradycardia. But once you give a full clinical dose,
Then you have enough drug to overwhelm the postsynaptic M2 receptors on the heart itself, and the rate shoots up into tachycardia. This is why, in a code situation or in severe bradycardia, we don't tiptoe around with 0.1 milligrams. We give 0.5 or 0.6. We want to skip the paradox and go straight to the tachycardia.
does glycopyrrolate do this? Does it have a paradoxical effect?
Much, much less so. The incidence of paradoxical bradycardia with glycopyrrolate is considered clinically negligible. Also, the character of the tachycardia itself is quite different. Atropine is the sprinter. It causes a rapid, marked, sometimes alarming increase in heart rate.
And glycopyrrolate.
Glycopyrrolate is more of a brisk walker. It increases the rate, but it's generally more gradual and less severe than what you see with atropine.
Which would make glycopyrrolate a potentially safer choice for patients with coronary artery disease, where we're really worried about increasing myocardial oxygen demand.
That's the exact clinical application of that knowledge. You want to avoid those extreme peaks of tachycardia in a patient with CAD.
Okay, let's move on to secretions. Salivary and respiratory. We said glycopyrrolate is the synthetic one. Does that make it better at drying things out?
It is significantly better. Glycopyrrolate is a much more potent antisialagogue. Morgan actually states it's approximately twice as potent as atropine in suppressing salivary production.
Twice as potent. And what about the duration of that effect?
Much longer. A single dose of glycopyrrolate can keep a patient's mouth dry and suppress salivation for up to 7 hours. Atropine works, of course, but its effect fades much faster, often within just 1 to 2 hours.
So for a planned fiber optic intubation or for intraoral surgery where a dry field is absolutely critical for the surgeon, glycopyrrolate is the undisputed gold standard.
Absolutely, it is the dry mouth champion, no question.
What about the lungs? Let's talk about bronchodilation.
Both drugs cause bronchodilation. They do this by blocking the M3 receptors on the bronchial smooth muscle.
Right.
And this leads to an increase in anatomic dead space. That's a physiological point that often gets brought up in higher-level exams.
Because if the airways dilate, the volume of gas that's not participating in gas exchange inherently increases.
Correct. Clinically, both can be useful in treating intraoperative bronchospasm, though, we usually prefer to use beta agonists or increase our volatile anesthetic. However, KDT notes that glycopyrrolate is often preferred in patients with chronic lung disease.
Why is that?
Well, because it dries the secretions more effectively without perhaps thickening them as much as atropine might, although that whole thickening concept is a bit debated in the literature. But the key exam point is that both are effective bronchodilators.
Okay. Let's talk about the GI tract, the effect on motility.
Both drugs will reduce the tone and peristalsis of the gut by blocking M3 receptors. They are effectively antispasmodics.
But for anesthetists, the big concern is always the lower esophageal sphincter, the LES.
Yes. And unfortunately, both atropine and glycopyrrolate reduce the tone of the LES.
Which, theoretically at least, increases the risk of gastroesophageal reflux and aspiration.
Exactly. This is the primary reason why we stopped using them as routine premedication for every patient. In the past, everyone got an IM shot of atropine or glyco before coming to the theater. Now we weigh the risk of aspiration against the benefit of drying secretions for that specific case.
Okay, let's quickly hit the CNS effects again in this section just to nail down the pharmacodynamics.
Right, so atropine, being our tertiary amine, our stealth agent, crosses the BBB. At normal clinical doses, say 0.5 milligrams, you might see some mild sedation or maybe nothing at all. But at higher doses, or in vulnerable brains like the elderly, it can cause excitation, restlessness, hallucinations, and full-blown delirium.
And glycopyrrolate.
Zero CNS activity that does not cross. It is CNS stable. It's a key safety feature.
Perfect. Moving on to pharmacokinetics, the numbers game. Onset of action, how fast do they work?
Atropine is faster. There's no contest. AV onset is about 1 minute. The peak effect is around 2 to 4 minutes.
And this is why it's the drug of choice for cardiac arrest or severe, life-threatening bradycardia.
Absolutely. When the heart rate is 20, you don't want to wait around. You need action now.
And glycopyrrolate's onset.
AV onset is a bit slower, around 2 to 3 minutes. Now, it sounds close, but that extra minute or two can feel like an eternity in a crisis. It's just too slow for a CPR situation.
What about duration of action? How long do they stick around?
Atropine's vagal blocking effect wears off relatively quickly, about 30 minutes, maybe an hour. Glycopyrrolate acts much, much longer. Its vagal blockade can last 2 to 4 hours, and as we said, the anti-salagogue effect is even longer.
Metabolism and excretion. This is vital for our patients with kidney problems.
Very important. Atropine is a hybrid. About 50% of it is metabolized by enzymes in the liver, and the other 50% is excreted unchanged in the urine. Glycopyrrolate is different. It is largely excreted unchanged, primarily in the urine, but also some in the bile.
So in a patient with renal failure,
The clearance of glycopyrrolate is going to be significantly reduced. It can accumulate. The tachycardia and the dry mouth can last for a very, very long time. You need to be mindful of that and potentially reduce your dose.
and finally, in pharmacokinetics, the crucial point, placental transfer.
We touched on this with the chemistry, but let's formalize it for the exam. Atropine, being lipophilic and tertiary, crosses the placenta rapidly and easily. Glycopyrrolate, being ionized and quaternary, does not cross in any significant amount. And this forms the basis of the two-compartment principle that we have to apply in obstetric anesthesia.
Okay, I think we have the basic science down cold. Now let's put on our clinical hats. Part D, clinical uses in anesthesia. Let's start with atropine. When is it the absolute, undisputed drug of choice?
Okay, 3 main situations. Number 1, acute symptomatic bradycardia. If the heart rate crashes due to a powerful vagal reflex, like the ocular cardiac reflex during strabismus surgery, or deep peritoneal traction atropine is your answer. It's fast.
Okay, number 2.
Number 2, CPR. It's a cornerstone of the ACLS algorithm for bradycardia and PEA. Now, guidelines do shift over time, but it remains a fundamental resuscitation drug.
And number 3 is a bit more specialized.
Yes. Number 3, organophosphate poisoning. This is a specific exam topic in toxicology and pharmacology.
Let's expand on that. Why is atropine the specific antidote for organophosphate or OP poisoning?
Organophosphate compounds, like certain pesticides, work by inhibiting the enzyme acetylcholinesterase, and they do it permanently, or at least for a very long time.
So you get a massive flood of acetylcholine at all the receptors.
An absolute tsunami of acetylcholine
Sure.
at both muscarinic and nicotinic receptors. The patient effectively drowns in their own secretions. That's bronchuria. They get severe bradycardia, pinpoint pupils, and critically central respiratory depression. It's a full-blown cholinergic crisis.
So you need an antidote that blocks those muscarinic effects everywhere.
Everywhere, both in the lungs and heart, and in the brain. Glycopyrrolate could dry the lungs and speed up the heart, but it's useless for the central effects because it can't cross the BBB. It can't stop the central respiratory failure or the seizures.
But atropine can.
Atropine crosses the BBB. It treats the central toxicity. It's life-saving.
And the doses used for OP poisoning are insane compared to what we use in anesthesia, right?
Oh, it's a completely different world. We speak in micrograms or maybe 0.5 milligrams. For OP poisoning, you might give 2 milligrams IV every 5 minutes until you see signs of atropinization, drying of secretions, dilated pupils, a rising heart rate.
Yeah.
In severe cases, patients might receive hundreds of milligrams over a few days.
Wow. Okay, now let's switch gears to glycopyrrolate. When is it our drug of choice?
Number 1, as we've said,
Mm-hmm.
as an anticholinergic, it's the preferred pre-medication for any airway procedure where a dry field is needed. And number 2, its most common use in modern anesthesia for the reversal of neuromuscular blockade.
Specifically, using it in combination with neostigmine. We need to explain the matching principle here. This is a very high-yield exam concept.
It's critical. When we want to reverse a muscle relaxant, we give an anticholinesterase agent like neostigmine. This increases acetylcholine levels everywhere.
Right.
This reverses the paralysis at the nicotinic neuromuscular junction, which is what we want. But it also causes profound muscarinic side effects, most dangerously severe bradycardia. So we have to add an antimuscarinic to counteract that.
But you can't just throw any antimuscarinic in. You have to match the timing.
Exactly. You have to match the pharmacokinetics. Neostigmine has a relatively slow onset, maybe 7 to 11 minutes, and a long duration of action.
And glycopyrrolate?
Glycopyrrolate has a similarly slow onset, 2 to 3 minutes, and a long duration of action. They are pharmacokinetically synchronous. Their effect profiles rise together and they fall together. The result is a stable heart rate.
So what happens if you make the mistake of mixing atropine with neostigmine? I've seen it done.
It's a mismatch, a classic error. Atropine acts in 1 minute. Neostigmine doesn't really kick in for another 10, so what happens first?
You get a massive, unopposed tachycardia from the atropine.
Exactly. Then, maybe 30 or 40 minutes later, the fast-acting atropine starts to wear off, but the slow, long-acting neostigmine is still at its peak effect. And what do you get then?
Late bradycardia.
Late bradycardia. It's a hemodynamic roller coaster, and it's completely avoidable.
So the rule for the exam and for practice is neostigmine goes with glycopyrrolate.
Yes. And just to complete the picture, if you were ever to use the very fast-acting Anticholinergic, you would pair it with the fast-acting anti-muscarinic, atropine.
Fast with fast. Slow with slow.
That's the principle.
Okay, let's move into what can go wrong. Part E, adverse effects and limitations. Examiners love to ask about the downsides. We've mentioned it a few times, but let's dive deep into central anticholinergic syndrome, or CAS. What does it actually look like in a patient?
CAS is a spectrum. It usually happens with atropine or scopolamine, another tertiary amine. The patient in the TACU, the recovery room, might just be a little bit confused, or they might be agitated, restless, picking at invisible objects on their blankets.
Floccillation.
Floccillation, that's the word. Or they can have vivid, sometimes terrifying hallucinations. In severe cases, it can progress to seizures and even a coma.
The classic mnemonic is mad as a hatter, blind as a bat, red as a beet, hot as a hair, dry as a bone.
Exactly. And the mad as a hatter part is the central anticholinergic syndrome.
So how do we treat it? This is the key pharmacology question that ties everything together.
Okay, so the problem is too much muscarinic blockade in the brain. The logical answer is you need to increase the amount of acetylcholine in the brain to compete with the atropine. So you might think, I'll just give neostigmine.
But neostigmine is a quaternary amine. It's the tank.
Correct. It doesn't cross the blood-brain barrier. It will fix any peripheral signs, maybe slow the heart rate a bit, but the patient will still be hallucinating. You need to use physostigmine.
Why physostigmine?
Because physostigmine is a tertiary amine anticholinesterase. It's a stealth agent, just like atropine. It crosses the BBB, gets into the brain, increases the ATAs levels centrally, and it wakes the patient up, often dramatically.
So the antidote follows the exact same chemical rules as the poison. You use a tertiary amine to treat a tertiary amine's central toxicity.
Precisely. That is an elegant summary and a guaranteed high-scoring answer.
What about thermoregulation, the hot as a hair part of the mnemonic?
Atropine fever. This is particularly crucial in children. Sweating is a strange one. It's mediated by sympathetic nerves, but those nerves release acetylcholine onto muscarinic receptors on the sweat glands. It's a sympathetic cholinergic pathway.
Right.
Atropine, of course, blocks these muscarinic receptors.
So the patient loses the ability to sweat.
And if you can't sweat, you can't dissipate heat through evaporation. In a warm operating room, or if a child already has a fever, giving atropine can precipitate a dangerous spike in temperature, hyperpyrexia. KDT specifically warns about this in pediatric populations.
Does glycopyrrolate cause this as well?
It can suppress sweating peripherally, yes, because it blocks those same receptors on the glands. But because it doesn't cross into the CNS, it doesn't directly affect the central hypothalamic temperature regulation center. Clinically, however, atropine is considered the bigger offender for causing hyperthermia.
What about the adverse effects of glycopyrrolate? It seems much cleaner.
It is generally cleaner, but it's not benign. It can still cause tachycardia, which may be undesirable. The dry mouth, or xerostomia, can be intensely distressing for a conscious patient. And importantly, urinary retention.
Urinary retention is a big one, especially for an elderly male patient with benign prostatic hypertrophy, or BPH.
A very big one. Both drugs relax the detrusor muscle of the bladder and increase the tone of the sphincter via M3 blockade.
Yeah.
If you already have an obstruction from an enlarged prostate, a hefty dose of glyco or atropine can easily tip you over into acute urinary retention post-operatively.
Okay, let's move to Part F, special clinical considerations. We're applying all this knowledge to specific patients now. Let's start with pediatrics.
Right. The exam phrase you need to remember here is, children are rate dependent.
Meaning their cardiac output is directly dependent on their heart rate, much more so than in adults.
Yes. Adults can increase their stroke volume significantly to maintain their cardiac output. Neonates and infants have a relatively fixed, non-compliant stroke volume. If their heart rate drops, their cardiac output and their blood pressure drop linearly with it.
And on top of that, they have very high vagal tone.
Extremely high. The diving reflex is incredibly strong in infants. Laryngoscopy, suctioning, hypoxia, almost everything can cause profound bradycardia in kids.
So in that situation, do we use atropine or glyco?
Historically and clinically, atropine is favored for both emergency treatment of bradycardia and often for premedication or at induction in neonates, especially if you're using a drug like suxamethonium.
Why?
We want the speed. We want the sprinter. We need to get that heart rate up instantly to preserve perfusion to the brain and organs. And the minimum dose in children is usually 0.1 milligrams, regardless of weight, specifically to avoid that paradoxical effect we discussed.
Makes sense. Now let's go to the other end of the age spectrum, the elderly.
Here, the opposite logic applies. The elderly tend to have lower vagal tone. They have, let's say, fragile brains that are much more prone to post-operative delirium and confusion. And they very often have underlying ischemic heart disease.
So we want to avoid tachycardia, and we absolutely want to avoid any CNS penetration.
Exactly. Therefore, glycopyrrolate is the drug of choice in the elderly. It respects the brain because it doesn't cross the BBB, and it's generally gentler on the heart rate, meaning less risk of inducing ischemia.
Now, for the section I find most interesting, and it's a huge exam topic, pregnancy. This is where the two-compartment model comes into play.
This is a classic Viva scenario. You have two patients you're responsible for, the mother and the fetus. And they are separated by that semi-permeable lipid membrane, the placental barrier.
Okay, lay out the first scenario.
Scenario A. The mother is having a C-section under spinal anesthesia. Our heart rate drifts down to 45. She feels nauseous. Her blood pressure is dropping. But you look at the CTG, the cardiotocograph, and the fetal heart rate is 160. The fetus is fine, maybe even a little tachycardic from maternal hypotension. You need to treat the mom if you give atropine.
Atropine crosses the placenta. It will speed up the mom's heart, but it will also speed up the fetus's heart. The fetal heart rate might shoot up to 200.
Which completely confuses the obstetrician. Is the baby suddenly in distress? Is it hypoxia? Or is it just the drug you gave? You've muddied the clinical waters.
So what's the correct choice?
You use glycopyrrolate. It treats the mom's bradycardia effectively, but it bounces off the placenta. The fetus is completely unaffected. The CTG remains a pure signal of fetal well-being.
That is elegant. You're treating a maternal compartment only. Now, what's scenario B?
Scenario B. The surgeon is manipulating the uterus, or maybe there's some cord compression. The mother's heart rate is fine, it's 80, but you see a sudden severe fetal bradycardia on the monitor. The baby's heart rate has dropped to 60. You can't start an IV on the fetus in utero.
So you have to use the mother as a conduit to deliver the drug to the fetus.
Exactly. You give atropine to the mother of the ear, it crosses the placenta, enters the fetal circulation, and acts as a form of intrauterine resuscitation. It directly speeds up the fetal heart.
And if you gave glycopyrrolate in that situation?
It would be completely useless for the baby. It would stay in the mom. She would get an unnecessary tachycardia and a dry mouth, and the baby would remain profoundly bradycardic.
That distinction, atropine for fetal treatment, glycopyrrolate for maternal treatment when fetal tachycardia is undesirable, that feels like a pass-or-fail concept in an obstetric anesthesia Viva.
It absolutely is. You have to know it.
We're in the home stretch now. Part G, exam integration. We need to visualize the comparison table. The outline asks for an examiner-oriented table. So I'm going to call out the row header, and you give me the direct comparison. Ready?
Ready? Let's do it.
Row 1, chemical nature.
Atropine, natural tertiary amine, glycopyrrolate, synthetic quaternary ammonium compound.
Row 2, lipid solubility and barriers.
Atropine, lipophilic.
Yeah.
Crosses the BBB and placenta. Glycopyrrolate, hydrophilic, does not cross the BBB or placenta significantly.
Row 3, onset of action.
Atropine, rapid, about 1 minute. Glycopyrrolate, delayed, about 2 to 3 minutes.
Row 4, duration of vagal blockade.
Atropine, short, around 30 minutes. Glycopyrrolate, long, 2 to 4 hours.
Row 5,
Metabolism, atropine, 50%. Hepatic metabolism plus renal excretion. Glycopyrrolate, primarily renal excretion unchanged.
row 6, cardiac effect on heart rate.
Atropine, marked rapid tachycardia. Paradoxical bradycardia is possible at low doses. Glycopyrrolate, mild to moderate, more gradual tachycardia.
Row 7, anti-sialagogue potency.
Atropine, moderate. Glycopyrrolate, potent, about twice as potent as atropine.
Row 8, CNS side effects.
Atropine can cause excitation, delirium, central anticholinergic syndrome. Glycopyrrolate.
Excellent. If the listener can just reproduce that table in their mind, They're in a great position. Now, let's cover the common Viva traps. Where do residents usually slip up on this topic?
Okay, trap number 1. Confusing potency with speed. Residents often think because atropine works faster on the heart, it must be a stronger drug overall.
But that's not true.
No. The correction is that glycopyrrolate is a stronger or more potent anticholinergic. Atropine is just faster acting on the heart. They are different metrics.
Okay. Trap number 2, the routine use question. The examiner asks, why don't we just use atropine with neostigmine all the time? It's much cheaper.
The safe answer there is, sir, the pharmacokinetic mismatch between rapid-acting atropine and slower-acting neostigmine leads to an unstable hemodynamic profile, with initial tachycardia followed by a risk of late bradycardia. Glycopyrrolate provides better hemodynamic stability. Don't just say it's better, you have to explain the PK mismatch.
Perfect. Trap number 3, treating the wrong toxicity. Examiner asks, your elderly patient is delirious in recovery after receiving atropine. How do you treat it? The student panics and says,
Neostigmine, which is a fail.
Mm-hmm.
Or glycopyrrolate, which is also a fail. The safe, correct answer is, I would use Physostigmine because as a tertiary amine, it is the only anticholinesterase that crosses the blood-brain barrier to treat the central toxicity.
Beautiful. And the final trap.
Trap number 4, the paradoxical bradycardia mechanism. Don't just say low doses cause bradycardia. That's a technician's answer. Explain the preferential blockade of presynaptic M1 autoreceptors. That shows you've read the big books like Miller and KDT.
Okay, let's talk about diagrams. If this is a written paper, a short note question, what should they draw to get extra marks?
2 simple things. First, the receptor schematic. Draw a cell membrane. Draw a little shape for the muscarinic receptor. Draw acetylcholine as a small key. Then draw atropine or glyco as a larger, different-shaped key blocking the lock. Label it competitive antagonism. It's simple but effective.
And the second diagram.
The structure sketch. You don't need to be a chemist. Just draw an N for nitrogen. For atropine, draw the N with 3 bonds coming off it. Label it tertiary, uncharged. Then draw an arrow from it going straight through a wall that you've labeled BBB.
And for glyco?
For glyco, draw the N with 4 bonds and a big plus sign next to it. Label it quaternary, charged, ionized. Then draw the arrow from it bouncing off the wall labeled BBB. That simple sketch is worth 2 marks instantly because it demonstrates the core concept.
That is gold. Visuals really do matter in exams. We are at the end of our time. Let's bring it all home. Part 15, summary and exam conclusion. Give me the high-yield takeaways, the final elevator pitch for the exam.
Okay, 1. Structure determines function. Tertiary atropine versus quaternary glyco is the key to everything. 2. Barriers. Atropine crosses the brain and placenta. Glyco does not. 3. Speed versus stability. Atropine is for resuscitation. It's about speed. Glyco is for routine reversal and premedication. It's about stability.
Go on.
4. Potency. Glycopyrrolate is the superior drying agent. 5. Toxicity. Atropine causes central anticholinergic syndrome. The specific antidote is Physostigmine. 6. Special populations. Atropine for kids and for intrauterine fetal resuscitation. Glycopyrrolate for the elderly, for cardiac patients, and for managing regional hemodynamics. And finally, 7. Reversal. Match neostigmine with glycopyrrolate. Slow with slow.
Perfect. And a final thought for the listener, that candidate standing outside the examination room door.
When you answer, always justify your choice with physiology. Don't act like a technician who is just following a protocol. Act like a clinician who understands the molecule. If you say, I am choosing glycopyrrolate for this case because its quaternary ammonium structure prevents it from crossing the blood-brain barrier, thereby avoiding the risk of postoperative cognitive dysfunction in this 80-year-old patient, you will not just pass, you will impress.
Remember the mantras. Atropine is the sprinter, glycopyrrolate is the marathon runner, and tertiary infiltrates. Quaternary stays put. Keep those in your head.
Go and draw that table right now, and good luck.
You've got this. Thanks for listening to The Deep Dive.